you for having me here, and thank you for organizing this wonderful conference. I'm sorry, I'm probably the only person who doesn't speak proper Spanish in the room, so because of me you have to go through the trouble of having everything translated, but I already appreciate it because I get the Spanish translation, how well that works, and thank you for having that set up as well. So I thought, today is meant for us to get to know each other, for us to get to know your children and to hear about your stories and the challenges that you face, the challenges that your children have been experiencing, but also for us to learn about the strengths and all the wonderful things that your children can do. But I thought that it would also be helpful for you to get to know us a little bit and to learn from us how we got interested in Major II and in studying Schaaf-Yang syndrome. So I'm a medical doctor, originally from Germany. I went to medical school in Germany and I did a thesis and dissertation in the field of genetics. And after graduation, I moved to the United States, to Houston, Texas, where I completed a residency in clinical genetics. So I am a clinical geneticist, medical doctor. And during my time in Houston, I got particularly interested in the genetics of neurodevelopmental disorders, in particular intellectual disability and autism spectrum disorder. And I had an outpatient clinic in which I saw many children with autism spectrum disorder. And it was in that clinic, I think in 2012, when I encountered Donnie. Donnie was a child from Arizona who was brought to me. He was 13 years old at the time, with an unknown condition that the family was told was similar to Prader-Willi syndrome. But at the age of 13, one of his major challenges was cognitive impairment. He needed special education and his autism spectrum disorder. And we performed whole genome sequencing on Donnie and identified the genetic variation in Major II, and he ultimately ended up being the first case known to us with this condition. In our database, we found 3 additional cases at the time who had already been sequenced, who also carried very similar mutations in Major II, and that led to the first publication in 2013. We called it Prader-Willi-like syndrome at the time because we felt that these kids, they had all been evaluated for Prader-Willi syndrome because they appeared to the clinicians to have a condition similar to Prader-Willi syndrome. That's why we called it Prader-Willi-like. And it was, I think, 2 or 3 years later when OMIM, which is an organization that kind of keeps track of all the different genetic conditions that exist and that are known, and they are also in charge of proposing names for the genetic conditions, when they decided to call it Schaaf-Yang syndrome. It felt humbling and a little awkward at the time to me. I didn't know how to feel that this condition carried my name. But over the course of the last 10 years, I've come to realize that it's a real blessing. It's been wonderful for me to have this name associated with your children because it has helped me to be so closely connected to the community and to so many families worldwide. And it has helped me to learn so much about the condition and also kind of have that extra bit of commitment of not giving up. So I've kind of pledged a promise that I won't be giving up. I will continue to study Major II and Schaaf-Yang syndrome, and I will try my best to help you and your families and your children to get to a better understanding and hopefully ultimately to also kind of find therapies, things that can help. Maybe one day we will be able to cure Schaaf-Yang syndrome, I don't know. But like every little bit helps, and like whatever I can do to improve the quality of life for you and your children, we will do our very best. So 6 years ago, after 13 years in the United States, my family and I have 4 children with my wife, myself. They're all little Texan babies. We moved back to Germany, and which is wonderful for us because we're much closer to our families, the grandparents, and can enjoy that kind of support and network from the family again. But I've also had the wonderful opportunity to be in charge of like one of the big genetics institutes in Germany. Heidelberg University has a lot of efforts in the field of biomedical sciences, and I'm the director of a genetics institute with many research labs and clinic and diagnostic labs. But in my laboratory, we study mostly 3 or 4 genetic conditions to which we have contributed over the years. And one of the main research projects is on Schaaf-Yang syndrome. So I have teams who investigate more the clinical aspects. Pilar is the research coordinator and really kind of my connection to the families, and also tries to keep track of all the information that comes in and coordinates the clinical studies, which has been wonderful. And obviously in this context it's even more wonderful because she's Spanish, so she can understand and also kind of help me understand the things that need to be addressed. I have a research team that investigates more the stem cell aspects. They do research with stem cells and differentiate them into neurons and like understand the molecular functions. Many of these cell lines have been generated from Schaaf-Yang families when we collected skin biopsies several years ago when I was still in Houston, and we make good use of those. We do use a mouse model of Schaaf-Yang syndrome, and more recently, actually the mouse model is not an ideal model, but for a long time it was the only animal model that we had. It takes out MAGEL2, so it's a deletion of MAGEL2. It's not the best animal model for Schaaf-Yang. But that has improved very much over the course of the last 2 years, because now there is a rat model that was specifically created to carry a mutation that is kind of the typical mutation of Schaaf-Yang syndrome, and that rat model I think will be very valuable to our ongoing studies. So we do breed the Schaaf-Yang rat, and we have a research team investigating both like physiologically in the brain, but also behaviorally, how much that rat recapitulates the challenges that we see in your children. We have one group that is particularly interested in oxytocin. You know that like the oxytocin system is one of the hormonal systems that's altered in Schaaf-Yang syndrome. So we have one group kind of addressing that. And then most recently, we had a new team member join. Her name is Raquel Gilmore. She is a postdoc who has been doing her PhD on the Prader-Willi locus. She's been interested in the snow RNAs in the Prader-Willi locus, but also their connection to MAGEL2. And she has been funded by FPWR, by the Foundation for Prader-Willi Research in the United States, to come to us in Germany. She's originally from the United States, to come to us and work with us for 3 years, only on MAGEL2 and some kind of the ongoing challenges in the research field. Like still we do not have a good antibody against MAGEL2. She'll be working on that. She will be trying to establish functional assays to investigate kind of how small kind of point mutations in MAGEL2 alter the function of MAGEL2 for us to help get a better understanding of the condition. So there's a lot going on, and like you all probably feel that, you know, the research is not going fast enough. You know, you want treatments today and not just like in 5 or 10 years from now. But on the other hand, I think when we take a step back and look at like how far we have come over the course of just about 10 years, it's really amazing to see, you know, how much insight we have gained, but also what a great and wonderful community has been created. We are currently in touch with approximately 400 families worldwide with MAGEL2 mutations. And to see that only in Spain and Portugal, you have 22 families, and so many of you having gone through the challenges of like coming here and being together is really wonderful. And I think that strong community can achieve so much. And I just want to congratulate you for the work you have done as a community. And I think together, we are strong and we will achieve so much more over the years to come. Thank you.
Schaaf. Yes, to welcome Ángel. Ángel, he's perdonar. He cambiado
Sorry, I was speaking in English. So Ángel, he's a researcher who's going to help us to do the moderation and to ask questions to Dr. Schaaf. But if it's okay for you, we can do a brief presentation on the families so that we can get to know each other. We will hand a microphone to all of you and just to introduce yourselves and to introduce your kids, and we can be sharing the microphone.
Hola. Empezamos por aquí.
Okay, we're going to start over here. Please try and be brief where possible, just so that we don't take too long with our introductions. Okay, I'm going to speak into the microphone.
Hola, me llamo
Hi, my name is Marcos. I come from Madrid. It's a pleasure to be here with Dr. Schaaf.
Hola, soy Lola.
Hi, I'm Lola. I am Sergio's mum. We come from Ávila, and I really am delighted to be here with all of you. I think this is all going to take us forward. Sergio is 10 years old, and he will turn 11 in December.
Hola.
Hello, I am Hugo's mum from Palencia. Hugo is 11 years old, and he was diagnosed in 2005. Wait, hold on. I got mixed up. 5 years ago is what I wanted to say. I'm sorry, it's so difficult.
Hola a todos, soy la mamá.
Hello, I am Jorge's mum. He is 21 years old. He's a big boy now. And he was diagnosed when he was 18.
Somos de Valladolid.
We come from Valladolid.
Hola, soy.
Hello, I'm Alejandro. I come from Mallorca. And I was diagnosed with Schaaf-Yang, I think, when I was 7 or 8 years old.
Somos de...
Hello, we come from Romania. This is Benjamin. He's 10 years old. 10. And what's your name? Benny. And are you delighted to be here? Yes.
Vivimos en Ávila.
We live in Ávila.
Hola, yo soy Sara.
Hello, I am Sarah. I'm the only case diagnosed in the Canary Islands after 14 years battling for a diagnosis.
Hola.
Hello, we are Mateo and John from Albacete. I'm sorry, I'm getting emotional. And this was Sofia.
Hola, soy...
Hello, I am Fanny. I'm Africa's mummy. I'm afraid Africa's a bit sleepy already. She's 7 years old, and she was diagnosed when she was 1 year old.
Hola, yo soy
Hello, I am Carles. I'm Marta's father. We come from Barcelona. Marta is 28. I think she might be the most veteran here, and we're very happy to be with you.
Hola.
Hello, I am Luis. I come from Portugal. I am Joanna's father. She was diagnosed in 2015 when she was 6 years old, and she's now 15.
Hola, soy Jesús.
Hello, I am Jesus. I am Christian's father. We come from Valencia, and he is 4 years old. He was diagnosed when he was 3.
Hola, soy Manuel.
Hello, I'm Manuel. I'm Manu's father. He's 7, and he was diagnosed this year.
Yo soy Juan.
I'm Juan. I come from Malaga. My son is called Jorge. I came alone. I didn't bring my family, but he's 8 years old, and he was diagnosed when he was 5 or 6. I'm not exactly sure. Hello, good morning. I'm Marta. We come from A Coruña. My son is Alex. He's 11 years old, and I'm going to see if he can stand up. Just a second.
Hola, soy Alex.
Hello, I'm Alex. Thank you.
Nos queda una familia.
We have just one family left over here.
¿Vale? Hola.
Hello.
Yo soy muy...
So I'm Monica. I am 10 years old. And we come from Barbate.
Muchas gracias.
Thank you so much.
Pero espera. Vienes...
But wait a second, I want to say, she loves speaking.
Bueno, ¿alguien más quiere presentar?
Would anyone else like to introduce themselves? No? Okay, well, as they mentioned, I research rare diseases, not this one in particular, although I would love to work on this one at some point with this amazing team that you have here. We have the finest expert worldwide and the very best team in Spain, and they are here. This Congress in Europe, it's not possible anywhere else, so we have to really leverage this situation and take advantage of it as families and as researchers later on, because this moment is truly just an alignment of the stars. The stars have all aligned, and we really have to seize this opportunity and thank everyone for coming from elsewhere. It's been a lot of hard work for Ricardo, who's around, and for all of the rest of the team. It's been a huge effort. I wanted to just make one comment. Whenever we do presentations, we always talk about the 3 legs of the stool of research, and one of them, of course, is your leg. It's the patients, the associations, the families. The other are the doctors, in this case, Dr. Schaaf. And then there's also the research side of things, and there has to be communication between all 3 legs of this stool. It's crucial to ensure that everything can move forward at the right speed, at an amazing, staggering speed. It's such a powerful interaction. And I think you will agree with that. It's fundamental to make sure that we can drive this forward and keep it going. And so now what I think we're going to do is, if you have any questions to ask, Ricardo has been gathering a few general questions that you've been raising. I have a few written down that I think are very relevant and really important to ask. Some are quite, let's say, broad, quite general, to help us understand medical and scientific concepts that perhaps those of us who are in the clinical research side might find quite clear, but it might be important to explain them just so that everyone else can understand them too. And then a couple of questions that I personally would like to ask you. I have a list of these questions that Ricardo has gathered, but what I think would be ideal would be for you to ask them, and we have the translators here, the interpreters can help you ask your questions directly. And what I would like you to do is be quite understanding. Don't say, hey, it's my mic and I'm just going to hog it so I can ask all the questions, okay? So let's try and keep it dynamic. Let's share the mic. Let's share the question, because my questions are mine, but they're also other people's questions. So now I'm going to address the table. Thank you so much. My first question that I would like to ask, let's see, I've got them written down here because I don't want to make any mistakes. Dr. Schaaf has been talking about the treatments, the animal models. He's also been talking about new perspectives. And there are 3 concepts that I would really like to look into a bit more, although they're quite general, especially just to avoid information issues, because right now in Europe and in the USA there is a legislation, a regulation on medical control that differs from the US. We have the FDA, the Food and Drug Administration, which is the equivalent to the European Medicine Agency, the EMA, and the regulations that they apply are different. So if you're reading on the internet or elsewhere that medicines are being approved in the United States, it doesn't mean to say that in Europe or Spain or Portugal they are approved yet. So first I want to raise this question, because I think maybe this is the kind of question that comes up. Why are they treating people with this, and why can't my son have this treatment too? So perhaps if you could try and answer this question, we'll kind of open the debate a bit with more broad questions like this, to just talk about the state of the art and what the current situation looks like, and then we'll maybe go into more specific things. Thanks. I don't know who'd like to start, Dr. Schaaf, Roser, Pilar, whoever would like to.
So it's the easy question to start with. I think, we're facing multiple challenges here. I think the biggest challenge is that we're dealing with a ultra-rare condition, right? Schaaf-Yang syndrome, and you realize that there are currently 22 cases known in Spain. There are less than 20 cases known in Germany, actually, that we're in touch with. There are, many more cases in the United States that have been diagnosed. But still, like even in the United States, it's probably 200 cases. So it's an ultra-rare condition. And that comes with many challenges. The first challenge is hard to find people who are specialists for Schaaf-Yang syndrome. Now, people would consider me a specialist for Schaaf-Yang syndrome, but even I, have so many things that I do not yet know and do not yet understand. So it's like, walking in like a foggy forest and, trying to take one step at a time. But, for families it's really hard. Like, not everybody lives in Madrid and has like, the best care possible in Spain. And it's like families ask me, where do I find a specialist, like who can prescribe this or that medication for me? Or they have a physician who's willing to take care of the kid and do his or her best, but does not feel comfortable prescribing prescriptions because they're not yet approved by the European Medical Association. There are a lot of things that we can learn from the Prader-Willi community, because obviously there's been a lot of work done in Prader-Willi, and the Prader-Willi community is pushing hard, like getting new medications approved. But it will take so much longer for Schaaf-Yang syndrome to have these formally approved. And it may never happen because the pharma companies, oftentimes are not particularly interested in developing drugs or getting drugs approved for ultra-rare conditions if they have like a bigger market that they can go after. I'm not particularly sure whether we need to go for formal approval with the FDA or the EMA. I mean, it's a process that also I do not have any experience with. I've never gone through this process, but I don't know if that needs to be our primary goal. I can speak for the situation in Germany, and that's kind of a similar situation in the United States, and I'm sure it's not that different in Spain. We as physicians can prescribe medications off-label. They do not need to have a formal approval for this indication, Schaaf-Yang syndrome, in order to prescribe them. However, you need to find a physician who's willing to take the risk, because when I, as a physician, prescribe a medication off-label, I take a risk together with the family, right? I say, well, it's not formally approved, there's not been a huge process that this medication has gone through with safety testing and really proving that it's useful for this particular condition, but I believe that it's worth giving a shot. I mean, it's the best that we know today. And this is kind of what we do for recombinant growth hormone. I mean, I've learned from many of you last night and this morning that several of your kids are getting recombinant growth hormone. It's not formally approved for Schaaf-Yang syndrome, not in the United States, not in Europe. But learning from Prader-Willi syndrome and studying the growth hormone levels in Schaaf-Yang syndrome, and then having done several treatments off-label and hearing the experience from the families, we think, yeah, this is something that we have on hand, and it's something that's worth trying, and we've seen the good benefits in many children. So I think this is the road that we're taking, and recombinant growth hormone has been the first medication of that kind that we've been trying in the community. Currently, several physicians are prescribing oxytocin, also off-label, and there's different concepts, but the general concept, it seems, is if children have severe feeding difficulties in the first 3 or 4 months of life, physicians are prescribing intranasal oxytocin to help overcome the severe feeding difficulties. There's some other physicians I know in the United States who are also trying intranasal oxytocin in older children, but I think the evidence to do that is much lower. So it's kind of a situation where we as physicians and you as families have really to identify ourselves as a team. We have to build a team. We have to trust each other. We have to realize that the safety net, is not perfect because these things have not gone through extensive studies. But if we feel that, there's safety data about this drug known in the pediatric population, not particularly in Schaaf-Yang, but the safety data look good, and we feel molecular data from our lab suggests that it's worth a try, and maybe something has already been tried in Prader-Willi or other conditions. We as a team of physicians and families have to decide, okay, let's give it a shot. We'll watch it very closely. If anything comes up that's unexpected, you need to call us and let us know, and we may need to stop. But if we're willing to take the risk together, we can also probably see the benefit. And this is the situation that we're in, and realistically, I think this will be the situation at least for the next 5 to 10 years.
Thank you. Gracias, Dr. Schaaf.
Thank you, Dr. Schaaf. 2 broad questions as well. One is it's a question that several families have raised, which is to do with the percentage of likelihood of transmission from the father or the mother. It appears to be well established that it comes from the father, despite the fact that mutations have been detected in the mothers. So this concept of transmission, of imprinting, I think it might be good to explain it to the audience, because it's a genetic concept and it often isn't entirely clear.
A ver. Esta también es difícil, ¿eh?
This is a tough one too. Can you hear me? Okay, great.
I have extensively introduced myself, but maybe the others, when they answer questions, can also briefly introduce their role and what they do.
Bueno, sí, estáis traducidos, que se van a presentar.
Vale, yo soy
I am Susana Balcells. I am a professor in genetics at the genetics department, microbiology and statistics at the University of Barcelona, as Noelia rightly said earlier. So, yes, this whole concept of imprinting, I have to teach this in my classrooms, so I can explain it. But normally, I use diagrams, pictures that are really helpful. And I have students who, let's say, might have a greater medical understanding than the audience we have here. But I think you are much more interested than most of my students. So let's go. MAGEL2, which is the gene we're discussing here, we receive it from mum and from dad, and it's in chromosome 15 in a region which, for evolutionary reasons, which I think might be quite difficult to share with you, in all mammals, it has been decided that there is one part of this region which is going to be closed and dark in the mum chromosome, but is going to be functional in the chromosome we received from our father. It's a region, just a small part of chromosome 15 that contains several genes, one of which is MAGEL2. Not just MAGEL2, okay? It's a whole region which works like this. The father's side is active and the mother's side is dormant. It's like switched off. So children with Schaaf-Yang receive the MAGEL copy from the male chromosome number 15 with this mutation, this truncated MAGEL2 chromosome. And in the mum's side, there is a correct copy, which in other circumstances would be the one that could give the functionality we need so as not to have that disease. But it's switched off. And during transmission, in many cases like those we have here in the room, in reality, the mutation has emerged de novo. So it appears in the sperm or in the precursor cells of that sperm, and it only affects a boy or girl born with the disease. And so the father doesn't actually carry this mutation in all of their lines, in all of their sperms, and may not transmit it ever. And this disease comes up just one time. But there's a more subtle concept. There's the fathers, the sons, the grandchildren. So let's assume that a mutation that can lead to Schaaf-Yang is in the mother's chromosome. She may have transmitted it to her children, to her sons and daughters, and they may not carry the disease because her copy is switched off. But let's assume that there's a boy at one point in the family who has inherited this from the mother, but they don't know, there's never been any clinical manifestations, but this boy grows into a man, becomes a father, and does transmit this chromosome 15 with the mutation. And so then it's the open chromosome, and the son or daughter of this man will have Schaaf-Yang in that case, and he carries the mutation. If we perform the test, we will find that he has that mutation. So if he has it and has a son or daughter with Schaaf-Yang, they may have more children with Schaaf-Yang. How many? What proportion? Well, he has 2 chromosome 15s, so half the times he will send one and half the times he will send another. So the likelihood of that man having children with Schaaf-Yang is 50%. Okay? So every new child is, let's say, a lottery. But it's going to be a 50-50 chance. Is it clear up to now? So there are mutations that can cause Schaaf-Yang that may be carried down from our ancestors through the families as long as they're traveling through the woman. Okay? But it is when a boy carries that mutation that they've inherited from the mother, but they don't know because they don't have the symptoms and they never can know, they're going to have a child, 50% chance of having a child with this syndrome in all of the children that man has. That's why sometimes there are family trees where Schaaf-Yang emerges in different branches because they are connected to, let's say, a great-grandmother, a great-great-grandmother, and they've travelled down from different sides of the family through the women. Okay, is it clear more or less? Is that what you wanted to know? Yeah, I think so. Good. I think they're the ones who need to answer. Is that explanation clear? I have a question.
Sí, para asegurarme de que lo entendí.
Just to make sure I understood this right, you explained two different cases. The de novo is, let's say, unheard of. But the other one, so they're two completely different cases. If you haven't detected the mutation in the father, because usually when a son is detected to have a mutation or a daughter, they analyze the fathers too. So if the mutation hasn't been detected in the father, you can be sure it was de novo. Is that important? I think it's important to understand the likelihood of, if we have further children, whether it's likely to have that chance or not. I imagine if it's de novo, it's the same chance as anyone else in the population. But if it's inherited, that's when you have this 50% chance. All right, and let's add something. You really hit the nail on the head. I knew I was forgetting something. That's why I said, is this really the question you were asking? Yeah, there's this delicate question. What happens if this de novo mutation has happened in the germline of the father, but in the precursor cells that can lead to more sperms? This is what we call mosaicism, and it's a case of analysing the father's sperms to understand whether there is any trace of that mutation in any percentage, because that could then be the reason for another potential child carrying Schaaf-Yang. And this is called germ mosaicism because it can occur in an primary stage of the germline, where part of this germline carries the mutation, not just one isolated sperm. Does that answer your question? So it's quite a delicate topic.
Go ahead.
And maybe I can add a little to it, because, she has explained it so very well, but it's important in the medical context. It sounds like you could test the sperm and determine whether that father has germline mosaicism. This is actually something that is theoretically possible, but it's not offered as a test in the clinic. So basically the situations are, like explained, twofold. Like either we know that the father carries the mutation, and then we know for each future child it will be a 50-50 chance whether that child inherits the MAGEL2 mutation from the father or not. If the child does not inherit the mutation from the father, then for that child's children, the chances of passing the familial mutation on will be 0. But if the child inherits the mutation from the father, then we also expect that it will lead to the clinical picture of Schaaf-Yang syndrome. For you families where the parents were tested and it was shown that the mutation is not present in the father's blood cells, there is that little chance of a germline mosaicism that remains, and it's hard to determine how high that chance will be. So we know that the chances of having another child with Schaaf-Yang syndrome are higher than the general population, and they're certainly not 0. We estimate, and that's the number that we give to the families, that the chance of having another child with Schaaf-Yang syndrome will be no higher than 2%. But that's just an estimation based on what we know. We would actually have to go back in all the cases that we know, like how many familial cases we have had where the father tested negative. But I remember very well at least one family. It's the Hanners family in Kansas. They have 2 children, 2 daughters with Schaaf-Yang syndrome that come from the father, but when you test the father's blood, you cannot find the mutation. So this is one of those cases of germline mosaicism. that's why we recommend that if you have had one child with Schaaf-Yang syndrome, and even if the father tested negative, we do offer prenatal genetic testing in future pregnancies so that you can find out early, and if you decide to terminate the pregnancy because of that, that would be one option.
Una última pregunta. En nuestro caso...
One last question. In our case, for instance, when Manu was diagnosed, we both took the tests, and it was found to be in hers, not in mine. And so because we're talking about fathers, if she has major 2 truncation present in her chromosome and I don't, what happens?
So we would have to look very carefully at your reports and your situation, but if, like, Manu inherited the mutation from his mother, we would expect that it should not cause Schaaf-Yang syndrome. Like, we would actually expect that, like, if Manu has clinical symptoms, they would possibly be related to something else. But, like, based on our current understanding, we would not think that a mutation that's passed on from the mother to her child would cause Schaaf-Yang syndrome. Theoretically, there are mechanisms that could lead to, like, an expression from the maternal copy, which could probably be investigated in the laboratory and would be very interesting, and maybe Rosa can kind of follow up on that. But generally speaking, we would not expect that to cause Schaaf-Yang syndrome. So she says you need to talk. Yeah.
¿En qué laboratorios diagnosticaron?
In what laboratory were you diagnosed? Sorry, I can't hear you. We'll speak later.
Hola, buenas.
Hi, good morning. Our son is affected by the syndrome, so what's the likelihood if he had children of their children having them? Because our case is de novo. But does your son have the 2 chromosomes, one that's affected and one that isn't? 50-50 then. Yeah, we did the analytics and it doesn't come from us. You said if your son has children, then he's 50% likely to transmit it because he has one healthy chromosome and one not. So if he has children, half of them, in theory, would inherit. But this is all theory. So 50% chance. Yes, that's right, because in theory, these are statistics. So in theory, it would be half the chromosomes one time, half the other time. But statistics don't always apply, okay? There are families who have 5 out of 5 affected with syndrome, and there are others who have 5 healthy children, so it's hard to know. Thank you so much.
Hola. Quería preguntar si, por ejemplo...
I wanted to ask, if, for instance, the father is the one who carries it, do his siblings have the same likelihood of being carriers or transmitters? Yes, we've found families where it has been recommended that they do this extensive screening. It's quite simple. We're doing it in the labs. We've done it with some families, because it's basic in research. And so it could be de novo in that father, but it's highly likely that it comes from his mother, from the grandmother. So if that father has brothers or indeed sisters, they can pass it on. The sisters can also pass it on to their children, who could then have grandchildren. And really, it's so easy to do. It's not at all difficult. And what's the likelihood of the siblings having it? If it was the grandmother, it's 50%, and so it goes on. Because the case is that the brother has a son and doesn't have Schaaf-Yang. Well, we're delighted to hear that. If you times 50% by 50%, that's what you get.
So maybe I can also kind of follow up on that. When we find that the father carries it, he could have inherited it from the grandmother, but it could also be a de novo case in the father, de novo on the chromosome 15 that came from the mother. So in each and every situation, we don't know until we look. So we would recommend, if the mutation has been found in the father, to offer genetic testing to all his first-degree relatives, to his parents and to his siblings. And then, depending who's found to carry the mutation, we would offer testing to all the first-degree relatives of that person as well. But it takes a bit of detective work, and it takes, a physician working with you, kind of tracing it within the family.
Es complicado porque...
It's complicated because your husband's brothers may or may not want to know. They may be in good terms or not. So it depends on a lot of cases. We were talking earlier about how we all need to be very collaborative and work together as a team. And there's this educational side where everyone has the right to know, but also the right to decide that they don't want to know. In this country, we're lacking education in genetics and in bioethics, but it's everyone's right to know. And then it depends on how easy things are to carry out. If it turns out that the father lives in a hut on the mountainside and they don't want to come to their doctors, then it can be difficult. So we always talk about the theory here. Just yesterday, over dinner, Ángel mentioned something that I think is very important. He was talking about the social stigma that is very rooted here in Spain, of it being like a macula, like a stigma stain. So we have to educate, and that it's random, it's up to fate, to chance. And so we have to work socially to eliminate that stigma, that social burden, to make it easier to understand that, hey, there's a risk. Let's take measures without any blame or guilt. When in fact, everyone has some sort of mutation somewhere, but in this case, it's right here. But everyone else carries some sort of mutation. Nobody is free. No one's off the hook here.
Please.
Yeah, and just to add to that, so it's actually several millions of genetic variants that each one of us carries, right? So the idea of having a perfect genetic code is, weird. Like nobody has a perfect genetic code. We all carry millions of typographical errors in our genome. It's normal. And it's important to kind of address that also because, we don't talk about it much, but I'm sure like some of the fathers have experienced like feelings of guilt because they think, why did I kind of pass this on to my child? It's like one of those conditions where we know, okay, it has to come from the father. And so we may feel guilty about that, but there's no reason to feel guilty, It's not in our hands. There's nothing that you've done wrong. There's nothing that you could have done differently to prevent it from happening. And you've also passed on like thousands and thousands of positive traits to your children, which you don't think about. So we need to get rid of that guilty feeling. It's just like part of nature.
I guess that in the case of Manu, for example, it's the same in the transmission of that it's hidden in the feminine cases, in the feminine genes. So how does this happen? Well, maybe you can go slower on that question. I guess that in the Manu's transmission, it's similar to the adenoleukodystrophy, which is more or less hidden in women and it happens to men. Well, I guess that we're going to review the case of Manu. Well,
excellent.
Absolutely, yes. Yeah.
Sí, yo quería preguntar, abundando en lo que...
Yeah, talking about this, the possibility of this 2% in the de novo mutation, that there could be mosaicism from the side of the father. So if you have two kids, like in my case, I have two kids, one is affected, the other one no, the younger one. Is it convenient, even if parents do not have any mutation, is it convenient to conduct some examinations on the younger one is not necessary. And in the case that they did detect it, to put myself in the shoes of the other family, that will be convenient to conduct the exam, and we should do an exome or what? Maybe it comes from the mother, and maybe it's not seen there, and they can carry it. It's just, if they do not show the symptoms, maybe the kid know the probability they have, so that they can make a decision if they can have kids or not in the future, or the probability on continuing transmitting this on the father line if it's not expressed. In Spain, it's just conducted by the feeling of anguish. The kid is feeling this anguish. It's not described as far as I know. Maybe Dr. Schaaf is going to clarify this. But if you have the mutation, for the moment you have Schaaf-Yang. There's no asymptomatic cases. In genetics, we have a concept which is like incomplete permeating situation, in which it's not described. If you have two kids, one has the affection and the other one is healthy, it's assumed that the one that is healthy did not inherit this. Newborn, you can have some doubts. Maybe you've seen a baby, you have some doubts, and in this case it's conducted fast. So because if it's more not such a severe, you can do some interventions in the baby. But if time has gone by and the kid is right, it is assumed that he's not a carrier, because if he was a carrier, he would be suffering from the illness or the condition. It's just for anguish that people do this. It's just to get rid of that idea, of that cloud over your head, because it's not quite a burden to carry out this examination, and for the families it's useful. We understand it's worth it. That's it. You answered what we look at, and it's basically we are looking for this mutation, not with an exome. We basically do a CPR and the Anger's equation. That's the one that we did before the exomes, and it's much more cheaper and it's easier and fast.
So just one more point, why we do not need to test the healthy siblings of the Schaaf-Yang kids. So the concept of the mosaicism only applies to the germline of the parents, and in Schaaf-Yang to the germline of the father. But, for each and every child, it's only one sperm that fertilizes the egg and leads to the development of a new baby. So if that sperm did not carry the mutation, it will also not develop later, in that child, and will not cause mosaicism. So that's why, because we're only going through one sperm, we assume that healthy siblings of Schaaf-Yang children do not carry the mutation and do not need to be tested. And then also their children would not be at risk of developing Schaaf-Yang syndrome, other than the general risk of having a de novo mutation in the general population.
That's just the probability that anybody can have, even your neighbor. It's just the same. So it's the same statistics. And just to add up, because we are going to do detail, as Roser says, due to this feeling of anguish, and because the person has this awareness, let's do the test. And the bad luck thing would be that there's a de novo mutation in the maternal chromosome, and then this boy can transmit it without being him suffering the condition. This is just a very, very rare case. But in the world of great numbers, little things happen. Well, you can say maybe there's not necessary to conduct a test, and then later you can have a Schaaf-Yang. This is just a very rare thing. But, maybe when you can just mention this, because we're going to detail. But there's no high probability. So based on the responses, I have a doubt, but I think it's going to be interesting, and I'm going to combine with other two questions we have. First, an explanation of molecular biology, just what you mentioned here. We have our DNA, which is basically read or copied to the RNA, and it's the one that creates the protein, which is basically the soldier, the one that generates the function. So if we have a DNA with a mutation, we have a protein which is not exactly the way it should be, which is what we call the white type phenotype, or healthy clinically, right? So what it happens is that we have a protein that either it's not there or it's not working the way it should, and it's the one that shoots or triggers the illness. And related to this, we can have new techniques that will allow maybe the discovery of the mutations. You've mentioned that when you know, in the case of relatives, you just have to go to seek for that because maybe the brothers or sisters are going to have it in the same place. But if we are talking about other relatives like cousins or the grandparents, maybe if there are new techniques that could give us more information. This is one question. And then seeing the variability that we have here in the people affected in this room. Another question is that maybe there could be a second mutation, or maybe something that we have on the past or on the future, like downstream or upstream on MAGEL2, that can affect to have this variability on the illness, and at the same time the variability in the starting point of the illness when we have the first symptoms. Maybe the questions are too much, I don't know. Well, I think we can get started by the second one. Well, let's go for the first one. If this extended family, you would apply the same to the general population, or should we look for the mutation that we know? I mean, this doesn't make sense because it's either the one that the family has, or you're exactly in the same risk as everybody, the rest of the population. So when we're going to have a kid, we're just playing that lottery tickets. Maybe we're going to transfer many changes, new things, inherited things, with the best intention to have healthy kids. Some will be good, some others not, so that's a lottery. And it doesn't make sense to today apply this massive screening. It's just an ethical thing that is being discussed today. But, well, this is just another topic. And the phenotype variability, I think Schaaf could talk better about this, but it's not just upstream or downstream. It's that we are all unique and different. And not everybody has the flu in the same way. We don't behave the same way when we have a problem. We are not as nice, as open, as empathetic, whatever. This makes us be who we are. If there's kids that tend to be more sick, to suffer many illnesses, or not. And this is who we are. And it's going to have an effect on how we manifest any pathological process that we must face, Schaaf-Yang or any other illness. This diversity that we see in Schaaf-Yang is also seen in any other pathology or condition. So it's not only an upstream or downstream thing. Tomorrow we will also talk about the type of mutation maybe could be affecting, but there's much more because we are unique, we are individuals, and in every single aspect too when we are sick. So the starting point, the debut, when if there's maybe an age or a moment or inborn when there are no symptoms that we can consider, maybe, for example, the younger brother is not affected, is there any age in we could maybe think that beyond the genetic analysis, I'm just talking about phenotype as symptoms? Let's leave Christian this question.
I understood the follow-up question, but maybe I can kind of get started. I mean, we do see correlations between the exact mutation and the severity of the clinical symptoms. They're not perfect, but there are clear correlations. Like there's one mutation that we know that none of your children here has, I assume, because all of the cases that have been identified to date led to lethality. These children died either in utero while the mom was still pregnant, or at the time of birth, or very shortly after birth. There's one mutation, it's so severe, it does not seem to be compatible with life. Then there is the very common mutation, the C1996 dup-C, where one additional letter C is added at that particular site, which accounts for, I think, 40% of all cases of Schaaf-Yang syndrome that we are in touch with. That is a mutation, when we compare it to all other mutations, is also more severe, which, you know, is sometimes hard when a child is newly diagnosed and the family sends me an email. I had one of those cases just like 2-3 weeks ago, where the mother said, well, you know, I looked into the literature and you kind of talked about this mutation, and I realized it's more severe than others, and the average IQ intelligence quotients that we have reported when we tested children with this mutation, the average was only an IQ of 14. You know, that sounds really terrible. Yes, there are those correlations, and you know, they probably relate to the specific site where the genetic alteration is, which translates into a specific form of protein which disrupts the function within the cells. And Rosa and her team have done like some really important work to show us like why that is. But even with the same exact mutation, there is variability, and we see it even in the families, like the family that I mentioned before, the Hanners family. They have 2 daughters with this particular mutation, and they are different. Like one of them is somewhat more severely affected, took her longer to walk, like she didn't walk until she was, I don't know, 7, versus the other who started walking at 4 or 5. And like we all know this, like I have 4 children, you know, they do not have Schaaf-Yang syndrome. They are presumably neurotypical, but they're very different, right? And like we also know intellectually, you know, some of them, like mathematics, you know, it's just like very easy for them. You never have to kind of talk to them. They just do their stuff at school and you don't need to worry. And others, they have a really hard time getting the concept. And this is like in our genetic background. I mean, it's a blessing and sometimes it's a curse. You know, we're all so very different, and like we're not just determined by that MAGEL2 mutation. There's a lot of stuff going on in the background, and in some way, you know, it's not just about genetics. You know, it's also environmental influence, and this is actually our window of opportunity for us as physicians or therapists, and for you as parents. We're not just determined by our genes, and we can help, and this is probably our most important task. We should help our children kind of develop to the best of their potential. Their potential is different from a child that does not have Schaaf-Yang syndrome, and we have to deal with that. But there's still a range of how well they can do, and our job is to get them to the best possible. And I've seen, you know, your children, like through your support, you know, what they have accomplished and how far they have gotten. And it's not the end has not been reached yet. You know, they can do so much more, and they will continue to develop. I've seen children who are unable to talk, but they use sign language. I've seen children who use the picture boards, you know, on the computer and like a tool that helps them communicate. And so we should never give up, you know, and kind of help them kind of to reach their best level.
Hola, buenos días.
Un segundo.
Ángel.
So the question pending over there, because we are having, I think we're going so fast. So you were asking, and I think it's a good question, this window. And this is a question for Christian, is to say that if I have a kid, having a brother with an affection, and apparently my boy is healthy, when can I breathe? Can I rest? Can I say it's fine, I'm safe?
Like my understanding is that Schaaf-Yang syndrome presents at the time of birth. MAGEL2 expression is highest just around the time of birth. And as far as we know today, there are no like particularly toxic substances that accumulate in the cells that would lead to like a disease that gets worse and worse. In fact, and I will show this tomorrow, it's my opinion that it's a disease that somewhat gets better. I think the most challenging time is right after birth, A lot of you have experienced this. This is when you're afraid that your child may die. They're so complicated, they're intubated. You don't know if they'll make it out of the hospital. But many of your children have kind of come off the tracheostomy, come off the gastrostomy, and they start developing and reaching milestones. Still, some of the milder cases, maybe not all the symptoms are present at birth. I honestly believe if your child is 2 years old and has started like sitting, walking, talking, and does not have low muscle tone, and you haven't seen any symptoms, based on my current understanding, I could not envision that child to develop symptoms of Schaaf-Yang later.
Gracias. ¿Preguntas? Sí, por favor.
Buenos días. Yo soy la madre.
I'm Alejandro's mother, and Alejandro, he's adopted. And, well, when it comes to family, for him, it's important. Up till now, in his mind, he wanted to be a father in the future. And after listening to you, he said, well, I'm going to adopt too. And while I was listening to you, I thought that maybe for these boys, we can have some opinions, or we can have some options, like, for example, assisted reproduction. Could we choose embryos before? Maybe it's the better thing, right? What we usually recommend, well, here we have some social and religious issues coming in the middle. We have our different points of view. We would say it's the most practical thing. You choose the embryo before implanting the embryo. You're not going to choose a healthy one. You're going to choose a one that doesn't have the Schaaf-Yang mutation. This ethically, I think, is important because we all have that risk. But it's something that it's offered in many illnesses. When just one copy you manifest the illness, we are talking about dominant pathologies. We think that today it's a common practice, and it's something that it's being offered as a routinary thing. Yeah, in fact, I think that the national health system does cover some illnesses for this. And it's very important what Roser was saying. They're going to study that the gene to which you're talking about, it's clean, doesn't have any kind of mutation. Then the variability that you mentioned before about the 23,000 genes we have, I mean, and this could be any other thing. But this is not only important for your kids, but even for you. If you want to have more family, you can undergo this. You can carry this out. It's studies that are quite advanced, but ethically it's just the question there. But the doctors are compelled to do it. If they ethically don't want to do it, they have the obligation to send this case to other doctor. But if you want to do it, the doctor working with you has the obligation to deliver that service. Then ethically they can think whatever they want, but it's their work, their job. There's many cases when it comes to ethics in which it's important to clarify this. I also wanted to clarify about what Christian said before. He also mentioned a common mutation, which is habitual, 40% of the cases. Could you please repeat maybe the number or the name? I want to note everything down. And also that made me think that yesterday, all of the parents, I was speaking with many parents, commenting about the similarities and differences between our kids. And we realized that there's something that we knew, that there's a lot of variability between the cases when it comes to affection and the cognitive level, muscle level, motor level. But there's also some things which are negative or also positive similarities. Talking about with some parents, and my boy has a very good memory. For example, he remembers everything. He visually remembers and learns everything. So on the one case, I want to ask if there's more mutations like the one you said about this 40% of prevalence, and if there's any other mutations that have this prevalence. And so for the parents to know what kind of traits could be more likable to be in their specific case. Like, for example, doing some groups on types of affections, types of traits that we don't know. It's very exact, but to talk about just probability, like, for example, the kind of affectation that I can have, like, depending on the mutation I have, they can have a back problem or a muscle problem, or their cognitive ability is just to this level, or they don't have any cognitive ability. Because for parents, we are quite, I think everybody understands this, we need to assign resources to our resource management. Should I focus on logopedia or physical treatment or cognitive treatment? And we have to make decisions. We have to choose how many therapies my boy can go on, to prioritize. What do I teach more to him to seize better, I don't know, this kind of therapy or this other therapy? And I consider information is very useful when making decisions. We need to have this kind of information to make useful decisions. So, well, if we can dig deeper a little bit on this. Thank you.
Okay, so I'll start. So the mutation that I mentioned, and I'll also show it in the presentation tomorrow, and it's been written in like many of the publications, is at position 1996, and the mutation is called C:1996 DUP capital C. So it's a duplication of the letter C at that position. And this is by far the most common mutation. There's the second most common mutation is at the same exact position, a deletion of C, so one C missing, and that is the one that I mentioned before that is so severe that we think it's incompatible with life. So for the 1996 DUP-C, I don't know, I don't remember the exact number, but there's at least 70 cases that we are in touch with, and it's by far the most common. There are some other mutations where we are in touch with like 5 or 6 cases, but nothing even close to, that particular mutation. So my team and I, we are currently developing a clinical severity score. And we've put some work into this as to, which symptoms should we consider, how should we rank them. It needs to be done in a way so that statistically it's evenly distributed. But that is something that we will talk about more maybe in like a few months from now, and we'll probably also like publish that as a resource to the community, so that you and the physicians can kind of, you'll be asked certain symptoms, are they present or not, and that shows you like where your child is in regards of like clinical severity to all the cases that we know. And that will help us also to further kind of define the correlation between certain mutations and certain levels of clinical severity. In regards of like which symptoms are most important and which ones should we address as we have to distribute our resources, that's a really tough question, as you can imagine, because it's a tough question for you, it's a tough question for us. We have done what's called the Patient Voices study through the Foundation of Prader-Willi Research, where we asked families, what are the issues that are most relevant for you, and if we had a pill to treat just one symptom, which symptom would it be? And that has been, interesting in a way, as we also see how the preferences shift as the kids get older. Other things become more important that weren't quite as important at this early stage in life. And like just to kind of follow up on that is also something, there's a lot going on right now really in Schaaf-Yang research. The Foundation for Prader-Willi Research will launch a registry, like a global registry. What we do right now is really very basic. We just type in the mutation in like an Excel sheet and we try to keep track of everything, but it's like very minimalistic. It's not great. So the Foundation for Prader-Willi Research has done this for Prader-Willi for several years, and like hundreds and hundreds of families, They can do it through an app, or they can use it like online, and they can fill in information, and then physicians like us kind of curate the information that's put in to make sure everything is correct. But it also allows you to put in information longitudinally, which means over time, and that will be an important resource for the entire community, because then we will really be able to create evidence as to, because it's in a structured way. It's not just like what's given to us or what's written in the medical records, but it's in a structured way. All families are asked the same questions, and we can link it back to the mutations. So hopefully 10 years from now we'll be in a better position of really kind of addressing your question.
Gracias. Vamos.
Thank you. We are going to do a brief pause.